I'm Steve Tanney from George Washington University School of Medicine and Health Sciences. Wanted to welcome you all and thank you for coming here this evening to our Frontiers in Medicine program. This is something that the School of Medicine has been hosting for a few years now. And tonight we have our second installation in an occasional series on healthy aging. Just a couple of things. When you came in, you should have picked up these pads. If you have any questions during the presentations, please write them down on the pads, and we will have people come and pick them up, excuse me, pick them up from you for the question and answer period. I know there are people in the audience tonight who have supported GW Medicine. We want to make sure that we thank you for everything that you've been doing to help us bring the best in medicine to Washington and beyond. Reminder, June 9th, actually this isn't a reminder, it's something new. Our next Frontiers in Medicine session is Monday, June 9th. We're going to take a break from the healthy aging theme and focus on trauma and critical care, some exciting advances that are happening here at GW in those areas. So now I'm just going to introduce our Master of Ceremonies, Dr. Alan Wasserman, who is Chair of the Department of Medicine, and Eugene Meyer, Professor of Medicine. Dr. Wasserman.
Master of Ceremony sounds much better than moderator. I like that. I gotta remember that. Put that on my CV. Masters of Ceremony. Yeah. Terrific. I'm glad everybody's here tonight. I think we have a really nice presentations for you tonight. We weren't sure what to call this. We thought of maybe sleep or not, or sleep to be or not to be, but we went safe and we just called it what it is and what we're going to be talking about. Sleep and sleep disorders become epidemic in this country, second maybe to diabetes. More people have sleep disorders than just about anything else. And if you think you don't snore, then you probably know someone who does. Or more likely you do and don't know it. And snoring and sleep apnea and the problems that leads to has really become a major problem in this country. We have been very fortunate, and Dr. Jain joined us, geez, going on about 8 years now? Almost 10 years now, wow. As an expert and one of the early experts in sleep disorders, and help us develop the sleep center at GW, which just keeps growing and growing, mainly because of the prevalence of this disease. He is the director of our Sleep Disorder Center, and we'll be giving our first presentation tonight. Dr. Jain, nice to have you with us today.
Thank you, Alan, and thanks everybody for coming tonight. As Alan mentioned, sleep disorders have they haven't exploded. I think they've always existed. I think we just as a medical community are starting to recognize them more and more. And in 10, 15 minutes, there's no way that I'll cover the whole spectrum of all the sleep disorders that are there. What I'm going to focus on in this short presentation is how important sleep is for healthy aging, and unfortunately how aging does affect even the normal sleep. So I chose this as the first slide because most of us kind of are familiar with this. I am when my parents are visiting, and this is not like the post-lunch siesta. This is, you're talking about like 11 o'clock in the morning, or 7 p.m. when the news is being run, and the grandkids, they're busy watching the favorite program, but what's a granddad doing? They're sleeping. The question is that it's almost taken a mythical. It seems that it's normal if somebody is behaving in this manner, and what I'd like to do is tell you that it's not. So here's somebody who came to see me recently. He's 72 years old. He's retired, and focus on the retirement because I'm going to come back to that again. What happens with retirement is we lose routine. And sleep is very dependent on routine. And if you lose routine, sleep can get affected. So it's not uncommon for most of us to start developing sleep issues after retirement, okay? So he came to us. He himself doesn't feel that he has any sleep problems, but his wife thinks that he has a sleep problem. Again, something which most of us in the audience will be familiar with. What's his routine? He wakes up at about 5:30 in the morning. He eats his breakfast, he showers, he reads the newspaper for an hour or two, and then naps at about 8 o'clock in the morning, okay? He naps for maybe 1 to 2 hours, depending on the day. Then he gets up, he does a few things, maybe plays a round of golf, comes back, eats lunch, and then naps after lunch, okay? Then he gets up again. He and his wife both are retired, so they're watching TV at about 6:37 in the evening. And according to his wife, he's again napping. And he didn't think this was a problem. He thought this was normal, just like in that cartoon, okay? What he then does is that he surfs the internet from 8 p.m. to 11 p.m. Now, so when he was working, he was probably going to be asleep by this time. But now he's taking so many naps in the daytime, he doesn't feel he needs to sleep. House is quiet, so he surfs the internet from 8 to 11. And then he tries sleeping from 11 to 5:30, and that's the time when he has problems, and he cannot sleep. He has other medical problems, and again, this is something which we'll talk about, why when you have more medical problems, and unfortunately as we age, we develop more medical problems, and there is a correlation between the number of medical problems and the likelihood of having a sleep problem. Not a cause and effect relationship, but an association that seems to take place. He's on multiple medications, and again, we're going to talk about that. There's this concept of polypharmacy, which affects sleep. We don't pay attention to this, but we should be. Medications do affect how we sleep. He doesn't smoke, but he does drink a glass of wine, maybe two, with supper. So myth number one is that it's normal for old people to nap in the daytime, just like in that cartoon, okay? And no, it's not normal, okay? It's normal to be maybe taking a short nap in that post-lunch period, but if you're falling asleep in the daytime when you're not supposed to be falling asleep, then it's not normal, okay? The second myth that exists out there is that as we age, our sleep needs go down. And that's not true, okay? This is something we see time and again. People come say, yeah, I got my 5 hours, 6 hours of sleep. I think that's enough. No. If it's not enough for you when you were, if it was not enough for you when you were younger, it's not enough for you when you're older. So this is, one data slide. I don't know if there's a pointer here or not. But what this is showing is the duration of sleep across different age groups. So on the x-axis at the bottom, you see as we are getting older, and then these are these different stages of sleep. And what you see over here is that across the age spectrum, starting at about age 20, the total amount of sleep still remains about 7 to 8 hours. So we still need that much sleep. Now I want to point out something there, that 7 to 8 hours is in majority of us, but there are people out there who, even when they were younger, could get by 6 hours of sleep and felt pretty good. So the amount of sleep that we need, if it was less when we were younger, it won't change when we get older. It'll remain the same, but it could be anywhere from 6 to 9 hours. But majority of the people need that 7 to 8 hours of sleep at night. What does decrease as we get older is our deep sleep. The deep sleep does go down as we get older. We in sleep medicine don't know if that affects the restorative quality of sleep. We don't know that yet, but it's thought maybe that's one of the reasons why, in spite of sleeping, we may feel tired as we get older. This is a fact that our ability to sleep goes down. So our sleep needs haven't gone down, right? We still need the same amount of sleep, but our ability to sleep through the night does decrease as we get older. This is what we do in a sleep lab. This is what we study as people go through these different stages of sleep. I just put this up because on the top you see the sleep going through these different cycles in a very nice manner, and see at the bottom graph how fragmented that sleep is. You see, how many more interruptions there are. So that's what's happening as we get older. The sleep architecture does seem to change, and and it's also shown indirectly by the prescription use of sleep aids. So as we get older, this graph is just showing how the number of drugs that are prescribed sleep aids are prescribed keep going up. Now, I also want to point out, and I'll take questions in the end, sleep aids is not the answer to every sleep problem, by the way. Okay, and we'll talk about those issues in the question and answer session. Okay, but yes, sleep does get fragmented, and it's not uncommon for doctors to say, okay, here, take this medication. Okay. What's the reason why we worry about this? So, because sleep deprivation or sleep disturbance can cause problems. It causes difficulty in sustaining attention. It slows your response time. It causes difficulty with memory. It decreases the performance, and Dr. Rubik will later on talk a little bit about the sexual performance related to sleep that can also get affected. It's not just old age. And if you look at all these symptoms, the constellation of these symptoms, you can say that perhaps that's dementia or early dementia. Is it really early dementia, or is it just disturbed sleep? That's one of the messages I want to put out to the audience. So what are the factors that affect sleep as we age? I talked about medical problems. So if you have, the more the medical problems that you have, the more your sleep will be affected. And, I came across this while I was preparing this talk. I hadn't really paid attention to this, but this is just a CDC data showing that as we age, the number of problems that we have multiply. So, the dark bars at the extreme right, with each age, you can see the number of, that's 3 diseases or more. And you can see that up to 1/3 of all people above the age of 80 will have 3 or more medical diagnoses, right? So we know this in the audience, right? I mean, we keep getting labeled with one more diagnosis. And the more disease that we have, the more the sleep gets disturbed. Medications and polypharmacy is very important. Alcohol is a drug. It has varying effects. It definitely has an effect on sleep. It has a calming effect, it has a sedating effect. So most people say, okay, I'm in the habit of drinking a glass of wine with supper at night, and it perhaps puts you to sleep right away. So maybe that's why this gentleman who came to see me in the clinic was falling asleep while he and his wife were watching TV post supper because he had his glass of wine. But then the alcohol wears off, and as it's wearing off, it causes a rebound awakening. So if those of us who have a glass of wine with supper, we'll find ourselves feeling sleepy right after supper, but then we'll be up. If we have wine closer to bedtime, we may fall asleep with the wine. Unfortunately, people use wine as a sleep aid or alcohol as a sleep aid, but then in the middle of the night, we'll have an awakening. So if other factors are causing an awakening in the middle of the night, alcohol is not helping. Let me just go back for a minute. Can I go back in these slides? Anyways, I'm going to hold questions about the primary sleep disorders such as sleep apnea and restless legs. Dr. Wasserman already talked a little bit about snoring, sleep apnea, and its health consequences. I'll be happy to take questions in the end. But I wanted to talk about one more thing about old age and sleeping, and that's how our circadian rhythm changes. So this is another cartoon that I decided to show. This is, the evening news is bad enough, but now he's dozing off during the Today Show. So what's happening essentially is that our circadian rhythms are advancing. So we're becoming more of early morning people and early evening people. So what that means is, again, this is another case that comes to me, and I just, stuck to the age of 72, he starts feeling sleepy at 7 or 8 p.m. And this is a gentleman who's not having wine with supper. He's just naturally starting to feel sleepy at 7 or 8 o'clock in the evening. But, he feels that it's a very antisocial thing to do. This is the time, right? 7 o'clock. It's not my talk putting people to sleep. It's the circadian rhythm. And then he's obviously concerned about that, so he's postponing his sleep till about 10 p.m., right? Forcefully. He wants to remain awake because he doesn't want to be antisocial. But he cannot help it. He still will wake up between 3 o'clock and 4 o'clock in the morning. And most of us have had experience with, like older people in the house who start waking up early. This is very common in the nursing homes, by the way. Their supper is usually at 5 p.m., everybody's put to sleep at 7 p.m., and they're all up at 3 or 4 a.m. in the morning. Nurses don't like that, nurses' aides don't like that because this doesn't conform to their cycle. So they'll, either give them sleep pills or something else to let them remain sleeping till about 6, 7 in the morning. But they like to wake up at 3, 4 in the morning. It's a normal advancing of the sleep rhythm. I don't know if those of you can read that cartoon, but it says, how do you feel when you get up in the morning? And the patient's saying, amazed. Uh, so this is just a representation of what's happening. In the green bars or the horizontal bars is the desired night of the patient. Okay, they want to go to bed at 10, get up at about 6, like other people. But their biology is telling them to go to bed at 7 or 8 and get up at 4 in those the magenta bars or the violet bars. So what's happening is that these patients will come to us and say, why do I wake up at 3 in the morning? Help me. Okay? Or why do I have difficulty remaining awake at night? This is not really a sleep problem. It's just the fact that what's happened to them is that their sleep rhythm has advanced. So, those of you who've had experience with teenagers know exactly the opposite happens during the teenage years. They become night owls. Just after puberty, they remain up till about 1, 2 in the morning and like to get up at 10. And the exact opposite starts happening to most of us as we get older. It's normal physiology. Okay? Now, how do you solve this problem? How do you treat these people? You tell them to go to bed early and get up early. There's no problem. Right? There's no disease. But people don't like to do that because they say, no, this is not, my rest of the family is concerned about it. I can't enjoy like an evening opera or a concert. So what do we do in the clinic to them? We like to push their sleep rhythm the opposite way. And the way we do that is tell them to expose themselves to bright light in the evening hours. So remain in a lighted environment. And you can take melatonin in the morning. So this is the exact opposite of taking melatonin at night, which we use for people who are night owls. So this is some way, but again, something to remember that this is not uncommon for our sleep rhythms to advance as we get older. So I'm just going to leave you with these last few tips, and I'll take questions again in the end. But things that we can do to improve our sleep. Once you've understood a little bit about normal physiology, what is expected, try to maintain as much regularity in your sleep and wake times, including on the weekends. Okay? Avoid excessive time in bed. Bed is meant for sleep. So if you're, try not to watch TV in the bedrooms. Try not to be, come home from work or just after supper, go into your bedroom and just lay in bed reading and then drifting in and out of sleep. Just use your bedroom only for purposes of sleep. Have a relaxing bedtime routine. I had a patient who'd love to, go through his mail, check his bills just in that 30 minutes before sleep time, and, Comcast or whatever. He was just, he would go with that anger to his bedroom, and obviously sleep would be affected. So you have to have something more relaxing to do right before bedtime. Daily activity and exercise is always good for sleep, but exercise should never be in that 1 hour before your bedtime because that can be stimulating. So it should be in the daytime, but exercise definitely helps sleep. And exercise doesn't mean gym. I tell all the patients who come to the clinic, even if you're still working in your lunch hour, just go around, take a walk in the sun, and just go, a couple of blocks. That's exercise, And afternoon exposure to sun is a good thing for sleep, by the way, and for depression. Avoidance of caffeine, alcohol, and nicotine if you find yourself to be susceptible to those agents. Some people are not affected by those agents, but you have to listen to your own body, and if you are, avoid them. Try to maintain a quiet bedroom environment. Avoid excessive light in the bedroom, and just maintain a good, comfortable room temperature. And that's something I know sometimes the spouses have a fight about that. The temperatures can be uncomfortable for one spouse and not the other. Anyways, I'm going to stop there and take questions after everybody's spoken. Thank you.
Vivek, thank you very much. So when we were just trying to figure out what are we going to pair up, we like to pair things up. We were thinking, well, sleep, what else do you do in the bedroom? Well, watch TV. That was probably the other big one, but there was not much we can do about health and TV unless Dr. Oz was willing to come down and lecture to us today. So obviously the natural thing was sex, and, what happens? Well, I came across an article, and the reason that this came up was because we were thinking about what to pair this up with. In Palm Beach County in Florida, the largest growth in the incidence of venereal diseases is in the population over 80. More infections are seen in the emergency rooms in that county in the population over 80 than any other population. And therefore, something is going on in the bedrooms or somewhere else, or somebody's bedroom. And, you know, sex doesn't end at 40, 50, 60, 70, 80 anymore. And we thought it was interesting to talk about this. Now, Dr. Irwig has given medical grand rounds to the university on this on multiple occasions to talk about, because it's usually a topic for men, but we weren't going to just limit this for men, as you can see tonight, to talk about, you know, the issues men have with erectile dysfunction and inability to operate. So we thought he'd be the perfect person to come and talk to us. And you can see he's director of andrology, and I'll let him tell you what that means and what the problems that we have as we begin to age with sexual function. Michael, nice to have you here with us today.
Well, thank you very much for having me here. It's a real pleasure. And as Dr. Wasserman mentioned, sexual health in men is a really broad topic. So I'm going to speak about one of my areas of interest, which is the hormone testosterone, which is in all of our bodies, just in varying amounts. And you've probably seen a lot of TV commercials. There's a lot of this in the media, so I just hope to clarify some of these points for you. Okay, I'm just waiting for the next slide. Trying to advance it. Let me try another button. Okay. I may need some technical assistance here because I'm hitting all the buttons. Yeah, no, this is a pointer. Maybe is there a keyboard with arrows?
It should be this one.
Oh, okay, maybe
Big
this
one in the middle.
okay.
This is a pointer.
Okay, all right, thank you. All right, just to let you know, I do not have any affiliations with any of the companies that make any of the testosterone. Okay, so you've probably all seen some of these commercials. They're usually in prime time about low T, which stands for low testosterone. And it's really funny how this hormone actually gets its own letter of the alphabet. And there's all these commercials basically about, are you fatigued, are you tired, is your libido a little bit down, maybe you should talk to your doctor about it. And it turns out that there's actually a center called the Low T Center. And this was started in Texas, and it's almost like a chain of restaurants. You can actually drive into this center, and they'll do a blood test, and they'll give you a testosterone injection 1 hour later. And they've now multiplied, and I believe that there's over 40 and 50 throughout the whole country now. None in this area, fortunately, but I'm sure it's just a matter of time before they arrive here. So speaking of that, I'd just like to show you one of these videos and just a little piece on this. So if you can please play the video.
Market new drugs they've spent millions to develop. Tisha Thompson shows us why critics say it could end up hurting as much as helping you.
You've probably seen the commercials.
I have low testosterone. There, I said it.
The commercials call it low T. Doctors call it hypogonadism. But Stephen Braun calls it dangerous.
I really feel that the public's health is endangered.
If you've ever read anything on low T, there's a good chance Braun wrote it. He's not a doctor, but what's called a pharmaceutical ghostwriter.
Typically, you won't see my name on those things. You might see a doctor's name on them. And in every case, there's a drug company behind that with an agenda.
He says some men really do need testosterone replacement therapy because of surgery or a genetic condition. It used to require painful shots, but about 5 years ago, drug makers started selling an easy-to-use gel.
They looked around to see how they can expand their market, and one way would be to redefine the disease so that more guys could be diagnosed with this condition.
I figured low testosterone would decrease my sex drive, but when I started losing energy and became moody...
Braun says everything he wrote warned about the same vague symptoms: being moody, no energy, a low sex drive.
What I produced was the truth, but it wasn't the whole truth.
Braun now admits he left out a big piece of critical information. There's never been a long-term study on whether low T drugs can cause dangerous side effects. He and a growing number of doctors worry low T may be for men what hormone replacement therapy was for women. When millions of menopausal women were prescribed drugs, only to learn more than a decade later those drugs can cause breast cancer, stroke, and heart disease.
The truth is we don't know long term what the exact risks and benefits are.
Dr. Michael Irwig says men now flood his office asking about low T. More than half end up having other problems like diabetes and obesity, requiring a different solution: diet and exercise.
It is much easier to take a pill or to take a medicine rather than to change somebody's lifestyle.
Which may be why a recent study published in the Journal of the American Medical Association found prescriptions for testosterone have tripled in the last decade. And 25% of last year's patients who got those prescriptions had never even been tested for low testosterone, worrying some doctors that patients may be taking a drug they don't even need. The maker of one of the most popular low-T drugs, Androgel, told the News 4i team its medication has more than 10 years of clinical safety and published and post-marketing data, with therapeutic risks well documented in the prescribing label. The company says disease state awareness initiatives serve an important role by enhancing awareness of health conditions, educating patients about treatment alternatives, and referring consumers to qualified healthcare practitioners. But Braun worries too many men are possibly risking their long-term health, and knows he could be putting his career on the line by speaking out.
Unfortunately, I think I've helped fuel a misguided experiment in public health, which I don't feel great about, but if I can say something about it now, maybe fewer guys are going to just leap into this without knowing.
Stephen Braun says a lot of the magazine articles he ghost wrote were geared towards women because the drug makers know men tend to avoid the doctor, but women will make them go. As for the drug companies, we've put their complete statements on our website, NBCWashington.com. Tisha Thompson, News 4i team.
Okay, so I just wanted to bring out some of the points here. So it actually turns out that very little is known about sexual desire or libido. Most of what we do know comes from mice and rat studies. And basically it's a very complex interplay. There are a whole bunch of factors that are excitatory, and there are a whole bunch of factors that are inhibitory. So on the excitatory side, there are all these neurotransmitters such as dopamine, norepinephrine, oxytocin, and on the inhibitory side, there's more serotonin, opioids, and endocannabinoids. And it really is a complex interplay with the neurons as to all these different signals. So it is true that there are androgen receptors in the brain for testosterone, but you have all of these other inputs coming in as well. And just to show you here, this is what's the relationship between libido and testosterone. So the Massachusetts Male Aging Study was a very large and well done study, and they basically asked these men one simple question. It's to rate their libido. And those with the lowest libidos have the lowest numbers. So you can see there's a 0 to 6 category, a 7 to 9, a 10 to 11, and a 12 to 14, with the 12 to 14 having the highest libidos. And then what they did is they graphed out their testosterone curves. And you can see that it is true that those with the highest libido, 12 to 14, did have on average higher testosterone levels over here, but you can just see that there's such overlap among all these 4 different groups that it's only one part of the equation. And as was mentioned about testosterone and sleep, this is very important. And this was a very elegant study where they took young men in Chicago and they admitted them to the hospital, and they had them get a good 8 hours of sleep. And then they checked their testosterone levels very frequently. And then they had them sleep only 5 hours. And so they had partial sleep restriction. And the same men, when they slept for 5 hours, had a 15% reduction in their testosterone levels. So sleep is very important. And just to put a slide here about erectile dysfunction. So there is a little bit of an overlap here. I would say maybe about 5 to 10% of men with erectile dysfunction do have low testosterone. But I essentially view them as almost 2 different separate categories here. Most of the erectile dysfunction is actually due to aging. So it really starts to go up after about age 50. And by about age 80, half of men will have some ED. And there's also a slew of of medications, side effects of meds, and chronic conditions that are responsible. So it's essentially a vascular condition. Similar to the heart arteries getting clogged, other arteries also get clogged. But we also see this in depression and in nerve injuries, in heart disease, patients who are on antihypertensives, very common blood pressure medications. Antidepressant medicines are notorious for having sexual side effects, but also all of the chronic diseases that we see in clinic every day, such as diabetes, renal failure, high cholesterol, high blood pressure, and chronic obstructive pulmonary disease. All right, so thank you for having me here, and I look forward to answering your questions at the end.
So we want to make sure that we covered, all sides of this story because, it certainly is a less talked about problem of having, sexual disorders in women as we get older. So therefore, we asked Patricia Smith, who's assistant professor in OBGYN at GW, to come and just enlighten us a little bit about sexual health problems in women. Patricia?
Well, thank you so much for having me tonight on this dreary day. So I am going to talk about a very broad topic, menopause and perimenopause, and how all these symptoms of these at this time of a woman's life affects sexual health. So I'd like to cover. Basically, the symptoms I'm going to cover are not exhaustive. There are many symptoms, but I'm going to touch on the ones that are most common. And then basically just go over some, just not very deeply, but just touch on some of the treatment options that we talk about with a woman to help with these symptoms. So just so that we're all on the same page, I'd like to put some definitions out there on menopause and perimenopause. Because a lot of times in the office, a woman would come to me and she's having all these symptoms and she'll say, oh, but my primary care physician says that I'm too young for menopause. And I'm like, yeah, maybe you're not menopausal yet, but you're definitely smack into perimenopause. So first, with menopause, it's when the ovaries stop producing estrogen and progesterone, the main hormones in women. Now, later on, I'll touch a little bit on testosterone. The ovaries continue to make testosterone, but in a very, very low amount than versus a younger woman. So when a woman is menopausal, this is when she stops having periods or menses for 12 consecutive months. So many times prior to menopause, the periods, menses, are irregular, and that's one of the top symptoms of perimenopause. But when a woman no longer has menses and it's been 12 consecutive months, that's menopause. Now that's if she still has a uterus, so there are some other ways we can test if a woman is in menopause. So typically, menopause occurs in a woman's life when she's in her late 40s. The average age of menopause is actually age 51, but a woman can become menopausal in her early 40s, sometimes in her late 30s. So I love this button. Menopause is the new puberty. So there are several times in a woman's life where she's on a virtual roller coaster of hormones. So one is puberty, and that's for men too. Another is pregnancy, and then the other is perimenopause and menopause. So I kind of lump them together. But perimenopause is the transition time, just as in puberty, adolescence, the transition time. It's not one day you're, 12, and the next day you're fully blossomed. It's a transition. So with perimenopause, it's a transition time leading up to the last period. So, and what causes the symptoms is is associated with the fluctuating levels of estrogen, progesterone. So a lot of times patient will ask me, hey, can you test my hormones? And I'll tell her, well, there is a 99.9% chance that your hormones are in the normal level. So the symptoms are due to the fluctuations. How that exactly corresponds to that, we don't quite understand yet, but we know it's the fluctuations. So the bad news that I have to break to patients is that the average duration of perimenopause is 6 to 10 years. So it's not just one day you're perimenopausal, next day you're menopausal. It's a transition, so it's a little roller coaster. So hopefully we can do things to make the ride less bumpy, I guess. So common symptoms. So again, this is not an exhaustive list, but I want to touch on the most common symptoms that we see in this time of a woman's life. So one of the most common symptoms is when a woman has irregular periods. And I'll go through the list and talk a little bit about each of the symptoms. So another very common symptoms are called vasomotor symptoms. Hot flashes, if they happen at night, they're night sweats. And again, talking about sleep and sexuality, when a woman is having night sweats particularly, that is going to interrupt your sleep, and that's going to have some impact on other things. So sleep disturbance, very common in perimenopause and menopause. And associated with sleep, all of these things are interrelated, are mood changes. If you're not getting enough sleep, you tend to be grumpy. So this woman's not too happy here. And a common symptom that I see very often are women who come to me complaining of vaginal dryness and irritation. And with sexuality, this is a very big factor because this causes a lot of pain, irritation during sex, and who wants to have sex when it hurts? That's a cactus. And some of the things that Dr. Erwig touched on, decreased libido, yes, that definitely happens in women. It does have something to do with lower testosterone, but with many things, it's not just that, it's multifactorial. So again, many of these symptoms contribute to changes in sexuality in the woman. Many of these symptoms are interrelated. And however, these changes that we see are not alone contributed to the changes in hormones in menopause. A lot of these things are age-related too, especially the decrease in testosterone. And it's always important to remember that having less interest in sex isn't necessarily a medical condition, although a lot of the ads, especially on the male side, is this is a problem, you must go to your doctor, blah, blah, blah. If it's not causing a problem with the woman or her partner or both, you don't really need to seek treatment. So I'm going to talk a little bit about some of the symptoms that I brought up and how it affects sexuality and sleep. So hot flashes and night sweats are very common. About 70 to 85% of women are affected by this. Oh. Sorry. And the average duration of having hot flashes and night sweats is about 5 years. So it may start in the perimenopause and then it will continue into the menopausal period. So after she stops having menses, a period, and so it may last about 2 or 3 years after the menopause. Now I see a few women that unfortunately are in their late 60s to 70s and they're still having hot flashes. So, there are some reasons why we have to continue treatment, but it all depends on her quality of life and other medical conditions she may have. So definitely when someone is having severe night sweat and she's waking up in soaked sheets and pajamas, that is going to disturb your sleep. So if you have disturbed sleep, you are too tired for sex. So that is one interrelated way of how sleep and sexual disruptions can occur. So this lady is, I'm not sure if you could read this, but this stressed out looking lady is saying, this is what you get when menopause meets insomnia. So, so this is a very common symptom in perimenopausal and menopausal women. About 60% of women in this age group have sleep disturbance. And particularly night sweats can disturb sleep. The waking up in the soaked sheets, just having nighttime, several nighttime awakening periods. And again, with disrupted sleep, you're too tired for sex. So this lady is, typically I don't see women in this state, but they describe feeling this way, and not when they're not in the office. So again, mood changes, it's not just a simple, okay, this is a change in this hormone, therefore you feel like pulling out your hair. It's much more complex than that. But we do see emotional changes. Just as we see emotional changes in puberty and in pregnancy. We see mood changes in perimenopause and menopausal women. So a lot of times when you're too stressed out, you are too stressed out to have sex. So I'm sure you're seeing some pattern here. Regarding changes in the vagina and vulva. So this is definitely related to the decrease in estrogen. So we know that. So when a woman has decrease in estrogen, and again, it's a process, so we may start seeing this in perimenopause, so 5, 6, 7 years, 10 years before actual menopause, a woman may notice that, you know, sex is getting a little bit more difficult, more irritation during intercourse due to the friction. So the tissues in the vagina and vulva become thinner and less elastic. And if you have thin, less elastic tissue, that tissue is more susceptible to becoming irritated, sex being uncomfortable, even tearing and bleeding during intercourse. And of course, that doesn't really, allow for pleasurable sex. So this is the decreased libido is one of the most difficult to deal with because there's a lot of factors. One of the factors, however, is that libido is mostly testosterone driven. However, it's more complex than that, but the hormone of libido, the main hormone, is testosterone. So one of the factors of testosterone is that in women, the level of testosterone peaks in the mid-20s, and it slowly decreases with age, unfortunately. So much, in fact, that by menopause, the level of testosterone is about half of what it was in the peak in the 20s. So one thing is that the ovaries do continue, and the adrenals do continue making testosterone in women even after estrogen stops. So one of the things that we counsel women, like say when they're getting a hysterectomy or whatnot, is that if there's nothing wrong with the ovaries, we keep the ovaries in. This is unlike the older days when a woman underwent a hysterectomy and she had her ovaries taken out. This is still a very important endocrine organ. So, and as Dr. Erwick touched on, there are many medications out there that can decrease libido. Antihypertensives and antidepressants, and even oral contraceptive pills. A lot of times we place women on oral contraceptive pills to help them transition into the menopause, particularly when they're having menstrual disturbances, that alone could decrease or affect libido. So I'd like to touch on, and this is very briefly, I'd like to touch on treatment options, breaking it down to each of the symptoms that I presented. So with hot flashes and night sweats, one of the first things I talk to patients is about making lifestyle changes. So using natural fibers like cotton, bamboo fiber, and dressing in cool layers. Try to be in well-ventilated rooms and avoid trigger foods, and that depends on the person. It could be spicy foods, it could be alcohol, caffeine, right? So so again, she'll have. I usually have her keep a diary. Now there are, now if you go into the vitamin aisle, vitamin section, there is a special segment usually for perimenopausal, menopausal symptoms. So many of those are mixes of herbal supplements that contain phytoestrogens, black cohosh that may help somewhat with hot flashes and night sweats, but those are usually helpful in women with mild to moderate hot flashes. When a woman has moderate to severe symptoms, and that depends on the woman, but usually that means that she'll have symptoms at least 8 times a day, but it also depends on how the symptoms are affecting her life. If I have women saying, every time I get up and give a presentation in front of the board, I'm just soaking wet and it's very embarrassing. So that's something that's very much affecting her life. So we'll talk about hormone therapy. Again, this is beyond the scope of this talk, but many women can benefit from hormone therapy, and now we understand a little bit better about hormone therapy, and that younger women in their late 40s and 50s may not be at the same risk for things like breast cancer and heart disease and stroke. So that's always on the table for many women. And then also, if a woman has or does not want to be on hormone therapy, or she has contraindications, medical contraindications, there are other medications that may be helpful. Certain antidepressant medications in a group called SSRIs have been found very beneficial in decreasing hot flashes and night sweats. Also, a medication called gabapentin, that's a neurologic modulator, can help with hot flashes and night sweats, and can help with sleep too. So that's very useful in some women. And then medication that's used for not so much these days, but it previously used for hypertension, called clonidine. It usually comes in a patch. That can be helpful in some women. So for vaginal dryness, there are, as far as non-prescription aids, I always recommend water-based lubricants to begin with. So that is more for temporary relief of vaginal dryness before sex, during sex. There are vaginal moisturizers, and some of you may have heard of them. Replens is one common one that you can find in any drugstore, any grocery store. And this is more for longer term, meaning several days of relief from dryness. It usually coats the vagina and stays for about 2 to 3 days. However, if a woman is really suffering from a lot of vaginal dryness and irritation, the thing that is the most helpful is low-dose vaginal estrogen therapy. And I'd like to really stress that this low-dose vaginal estrogen therapy is just local to the vagina. So it's very different from systemic hormones that we use for things like hot flashes and night sweats. So it does not carry the same risk factors as those as systemic hormones. So another important thing is that if you don't use it, you lose it. So use it or lose it. Regular sexual activity or stimulation, it can promote vaginal health by promoting more blood flow to the area. So for sleep disturbance, as Dr. Jane said, good sleep hygiene, having a regular sleep bedtime schedule and avoid daytime napping. Regular exercise is also very, very important, but again, exercise right before sleeping can have a stimulating effect, so not before sleep. And avoiding excessive caffeine, using relaxation and meditation techniques just as normal maintenance of health. I think that's very important. Many sleep disturbance may be related to mood changes, or there may be comorbidities such as depression or anxiety. They may be helped with antidepressants, SSRIs. And also, when a woman is having a lot of mood disturbances, I always explore the option of undergoing talk therapy. So for decreased libido, again, I'd like to stress that it is not a requirement, it's not a disease. It's if it's bothersome to the woman or partner or both. So one of the first things I ask is, how's your relationship going? So like most things, including relationships, many people need a tune-up. So that's one of the things I recommend. Maybe the couple would like to go for therapy just for a tune-up. You don't have to have any major problems, but maybe just a little examination of what's going on. So another important thing is to go over the list of medications, because many medications have side effects as decreased libido. So if there are medications that may be affecting libido, we work with the physicians, and the woman may work together to try to come up with maybe alternative medications that may have less of an effect on libido. So, and sometimes these problems may be more profound, so that may require a specialist in sex therapy and counseling. And also, this is a little bit more controversial, but some women may benefit from testosterone containing products. However, these are not FDA approved, and we don't know what the side effects are long term. So again, this is something that a woman may choose to do, but we just don't know the long-term effects. And the amount of testosterone that we use in women is much less than we use in men, about 10 times or more fold less than what a man requires. And yoga is one type of exercise that may stimulate libido, but pretty much any type of exercise may be helpful. So I want to put this up. This is the logo for the North American Menopause Society. This is a very, very good website. I recommend you putting this down, but very helpful for all women, for practitioners, on very common symptoms that I talked about, and it talks about a lot and goes into detail about a lot of the treatments that we use for many of the symptoms that I brought up tonight. So I use this as a resource a lot. So in conclusion, menopausal changes that we see, perimenopause and menopause, can definitely contribute to the sexual functioning in a woman. And so, however, some of these changes are not related to just the changes in menopause, but are age-related, just like the decrease in testosterone. That is definitely age-related. And again, this is not a disease as far as decreased libido. If it is, it only is if it is bothersome to the woman, to the partner, or both. And remember, I mean, a lot of people feel a little bit shy, a little bit embarrassed about talking about these symptoms. And I just want to say that this is what we're here for, and we're here for you, and we're here to partner with you to help you with your symptoms. So thank you very much for having me.
Tricia, thank you. So I'm going to remind everybody again, if you have some questions, to write them down, and we'll start collecting them, and I'll try to get to as many as I can, and then we'll see how far we get. Vivek, let me start with you and ask, so should people never take a sleeping pill?
No, in medicine, never is never the right answer. But it's certainly, more and more, sleep physicians are now starting to go away from sleep medications because of the potential for side effects. And there are side effects which get worse as we age for most of these sleeping pills. And the big one that is there is the increased risk of falls. The example that I use in the clinic is, if I want to treat somebody with insomnia and treat them for, it's just the short term, then yes, it's like, 10 seconds, write a prescription, let them go home. But the treatment that's going to help them for the rest of their life is something called cognitive behavioral therapy, which works more slowly. It takes time to start working, but then it'll have, effects which are going to last you for the rest of your life.
So it's interesting. I two questions that just came up just recently is that I want to sleep at night, but my prostate wouldn't let me. What do you do?
Send them to a doctor, one of the urologists.
That's not you.
That's not me.
That's not you, right?
Yeah.
How can seniors prevent STDs? That's a great question. Know your partner, I guess, is the answer to that. And condoms is the other.
Always.
Yeah, condoms no matter what age you are. Vivian, a lot of people are questioning melatonin in the morning. It doesn't make any sense. Melatonin is supposed to be at night. How can you think melatonin in the morning?
Absolutely. I put that slide up because the melatonin is something that signals darkness. It's just a natural peptide that we all have that tells my body that it's dark outside. And these people who are waking up early in the morning because of the circadian shift, their brain somehow is not sensing that it's still dark out there. So that's the only reason for giving them supplemental melatonin. It's not something that I use commonly. In fact, the light therapy has a much bigger bang for the buck. So light at night will definitely help you become less of an early morning person. And it's rarely that I'll give somebody melatonin in the morning, but that's the answer.
So what do they do in Sweden when it's light all day and nobody sleeps?
Oh gosh, I tell you, that's a toughie.
It must be a sleep disorder doctor's dream, right?
It is, absolutely. Sleep's a big issue in these northern latitudes. It's highly correlated with higher risk for seasonal affective disorder, and it's more to do with these changes in light exposure. So people are using, like artificial dark shades or working in less lighted environments during the summer times and keeping houses artificially lighted up in the wintertime because it's the opposite problem there in the wintertime. So now that it's, one of the examples that I use, I don't know if you've been to, like a penguin enclosure at one of these, like theme parks. But, the penguins are exposed to these periods of darkness and lightness for 6 months at a time, right? And what they used to do is they bring these penguins from the South Pole and bring them to San Diego or Florida or something. And they used to keep them expose them to the light that we are seeing in San Diego and Florida. And they realize these penguins are losing feathers and dying and not reproducing and not eating or whatever. And now if you go to these enclosures, they are replicating the same light exposure that these penguins are used to down in the South Pole. So you go there in July and the enclosures are in total darkness. You go there in wintertime and it's totally lighted. And Sweden and all these countries are starting to do the same thing for humans because humans have not adapted. They're the exact opposite of the penguins. They've moved there much more recently in the evolutionary history. And so we haven't changed our light-dark exposure. We're still used to the temperate zones. And so they replicate that there. just like people do in the space station, just like they do in the submarines.
That's interesting. Okay, guys, I'm going to give this to two of you here, and that is, Patricia, especially you. You talked about using antidepressants for treatment. You've also talked about antidepressants as being the cause. I mean, the biggest complaint I hear, other than beta blockers, is antidepressants, as far as mostly some in men, but a lot in women. And I think people don't realize that, how SSRIs really can decrease libido and prevent orgasm in women. So I'm going to ask both of you to comment on the use of antidepressants. I mean, depression can cause sexual problems, and antidepressants can make them worse.
So I think one thing is basically talking to your physician, and when I talk to a woman about her symptoms, this is not a 5-minute visit. This is something that takes some time, because we have to go through, okay, well, what is the symptom that's bothering the most? And so we start from there, and then we have to go through her other medical problems. So if depression is one of her problems, and she's having decreased libido and hot flashes, I may not want to put her on an SSRI. We may talk about being on gabapentin, which is a neuromodulator, and if she's having problems with sleep, gabapentin may help with sleep. So it's not a one medicine fits all. It depends on what her symptoms are, what her other medical comorbidities are, and what her preferences are.
It's such a prevalent medication, though, that we use all the time. Michael, you
Right.
must see people on this all the time.
Right. So some SSRIs don't have as much of effect on libido as others. So some have a more neutral effect. So a lot of times I use a medication like Lexapro, which has a little bit less of an effect on libido.
So you'll switch them first before you do it.
Right, right.
Yeah, I mean, I would just echo that. I think that individualizing therapy is just so important here, and really having a thorough evaluation about the signs and symptoms and not just rushing into this. My personal opinion is that there is a subset of people who really will benefit from an antidepressant, but a lot of the studies show that the cognitive therapy and talking is just as effective as the medication.
But a lot more expensive.
And yeah, a lot more expensive, but doesn't have the side effects.
Dr. Perlin, I'm sorry.
So,
Yeah, that's only one of the big problems. Here's a great question, easy question. Does Medicare cover the cost of sleep studies?
Medicare, sorry?
Does it cover the cost of sleep studies?
It does, absolutely.
It doesn't?
It does.
Does?
Yeah.
Oh, God, I'm going to have a whole new topic tonight in 1 second if it didn't do that. Michael, testosterone and cancer. Prostate cancer, is it a cause of prostate cancer? Can it cause prostate cancer? If you have prostate cancer, can you not take testosterone?
yeah, so basically what happened was in the 1940s, when men were diagnosed with advanced stage prostate cancer, it was found that if you castrate them and if you lower their testosterone levels, that actually helped with the disease. Whereas if you gave them testosterone, that would essentially fuel the fire. So back in the 1940s, the concept of testosterone being bad for the prostate and prostate cancer developed. However, we're in a different age now where most prostate cancer is actually picked up much earlier at a stage 1 rather than being metastatic to the bone, for example. And there really is no strong evidence that if you don't have any prostate cancer, that giving testosterone will increase the risk of you developing prostate cancer. And there also is no evidence that if you have a very low-grade prostate cancer, like a stage 1, that it's going to cause that to grow. So based on the evidence, most people think that there is not a strong relationship here. But again, nobody has that randomized controlled trial like we have for women in hormones. So we don't have a long-term trial where men were given testosterone to follow them up for 10 or 20 years and see, okay, do they have more or less prostate cancer or heart attacks or fractures? So our current practice is just to monitor the PSA levels in men who do receive testosterone replacement therapy. However, there's still so much controversy about PSA even as a test because there are many things that will increase it other than prostate cancer.
So, but along with testosterone, and now let's talk about estrogen in cancer, because that's been the big scare and the big, since the women's health study came out. So now you're saying that younger women may be okay to be on estrogen, but if you're over 70 or 75, you've not had breast cancer, isn't there a safe dose of estrogen you could take?
Well, the thing is that women who are started on estrogen, and if you have a uterus still, you'll need both hormones, estrogen and progesterone. So when the Women's Health Initiative, the big study where in 2002, all the news came out, hormone replacement therapy causes cancer, and everybody stopped. Everybody stopped. Physicians stopped prescribing, patients stopped taking. So a lot of those women were older. The ones in the Women's Health Initiative, when they started the estrogen and progestin therapy, the average age was 63. And that's not a typical age where we start hormone therapy. The typical age that I see of a woman who's having hot flashes and vaginal dryness and all those the symptoms that I talked about are in their later 40s, mid 40s, early 50s. So it's been over 10 years since the initial scare came out, when the Women's Health Initiative was stopped abruptly because of this increase in cancer that we see, namely breast cancer, and an increase in heart disease and stroke. Now, what we have learned in the past 10 years are that women that are younger, namely women in the 40s and 50s, don't appear to have the same risk as women in their 60s and 70s. Again, if a woman in her 60s and 70s is having very bad, or continues to have very bad hot flashes and night sweats, it's not completely off the table, but it all depends on what her risk factors are. Does she have a risk family history of maternal family history of breast cancer, or personal history? Then it's off the table. If she has other comorbidities, then it may not be a good option for her. And as long as she understands the risks of the hormone therapy, and again, there is an increased risk, a statistically significant increased risk, but it's more in the category of rare increased risk.
So we've gone from no use to individualizing the therapy and making things make more sense.
Correct.
Vivek, what should I do if I wake up during the night and can't get back to sleep?
So again, one of the things that we go through is just go by history. What's causing the waking up? You mentioned a prostate problem earlier, but again, we talked about snoring. Snoring can wake people up, and certainly that will be a clue to doing a sleep study to rule out sleep apnea. Is there acid reflux? Is it other medical conditions that are waking you up? So I'm assuming that this question is related to where, no, there's no obvious cause. You're just waking up in the middle of the night and not knowing what to do at that time. We do something called stimulus control therapy. So in general, what insomnia is, this inability to sleep through the night, is a state of physiological hyperarousal. So the way we understand sleep now is that, if I use the analogy of a car, and I say the car drives around in different gears. So under normal circumstances, my car is driving around in the second gear, then comes the nighttime, my car goes into this neutral gear, and it remains there in that neutral gear before the morning comes and I wake up. But what happens in insomnia is that my car keeps coming out in the middle of the night into these first and second gears, okay? So it's a state where I'm not in control, but my car decides to rev up. Now, things that we do in the middle of the night that make that state worse is things like worrying about, oh my God, I woke up in the middle of the night. And something that adds to that worry is I look at the clock. Okay, I wake up in the night, I wanted to get up at 6, and I woke up sometime in the middle of the night, and I looked at the clock, it's 3 o'clock. So two things happened right away. I get angry. Why did I wake up at 3, the second thing that happens is, supposing you wake up and you were supposed to get up at 6, but it's not 5, and then you start debating with yourself, should I try to go back to sleep for another hour, or should I just try to go back to sleep, or should I call it a day? And that debate also arouses you further. So the things that I tell patients to do is, okay, if you got a time that you want to wake up, set the alarm for that time, turn the clock, and forget about time's existence before that. It's not going to affect you. Waking up, it's a normal thing. We all wake up in the middle of the night. Those people who come to me and say, I have no idea what happens in the middle of the night, I'm in such a coma, those are the people that scare me. We all have to wake up at least once or twice to become aware of the environment in the middle of the night. But most of us can go back from being in that transit first gear to the neutral gear right away. Those of us who remain in that first gear because we are scared of why did I wake up? And that clock monitoring adds to that fear. Okay?
So if you can't sleep, go buy a new car. Pretty much what you're telling us. Can you snore and not have sleep apnea, and can you not snore and have sleep apnea?
Absolutely,
Got
absolutely.
That?
Yeah. So
Okay.
in fact, that's a great question because especially as we get older. So in the older people, the sleep apnea may happen without snoring necessarily. So certainly in younger people, most of them will snore if they have sleep apnea. But the older we get, we can still have sleep apnea without necessarily snoring.
Yeah, okay, so there's no winning one or the other, huh? Michael, I can't let you get out of here without talking about Viagra. It's the biggest seller out there, or the Viagra-like drugs for erectile dysfunction. Is there an age where it stops working? What's the story on aging and those types of drugs?
Yeah, so basically the class of medicines came out in the late 1990s, and I believe that Viagra or sildenafil is going to go generic very shortly, which will be good. But there has been an explosion with all of these medicines. They all pretty much act the same way. They're all relatively the same amount of potency. They have a little bit of a different side effect profile, and they've really transformed how erectile dysfunction is managed because rather than doing all these complex evaluation, the first line is often just a trial of these. And in general, they work for about 2/3 of the cases in men. But you have to take them appropriately, take them in half an hour or an hour before, and you still need to have stimulation. So nothing just magical is going to happen just if you take the pill. Now, having said that, the good, so they work about
let me ask you, that's a good thing you just said. Do older men need more stimulation than younger men? And is the recovery time longer? Because some people think these things are abnormal.
Yeah, so there are a lot of changes with aging, with sexuality, and one of them is that older men do need more tactile stimulation, for example. They also have an increase in their latency periods and refractory periods, which means that there's going to be a delay in between the time that they have one sexual episode and the next sexual episode. So there are a lot of changes that do happen during aging. The good news for erectile dysfunction is that there is a treatment for almost everybody to get an erection. The bad news I tell patients is that if the pills don't work, the other treatment options tend to be much more invasive, which are injections into the penis of a medication, or even going to a surgical option.
Are these the Boston Clinic things that we hear about that come to us and Viagra didn't work? We have these other options. Are these the other options you're talking about?
Yeah, so there's actually nothing special about all these clinics that are on the radio that say 100% satisfaction guaranteed or your money back. Basically what they're doing is they're just charging several $100s for these intracavernosal injections, which we can do in our urology clinic, which is just a very simple injection that has a very high effective rate. The problem is that even though it's a small needle, a lot of men don't want to do that, and there are some potential side effects, bleeding and pain. And if you look at a year out, very few men are actually still on that therapy.
Patricia, one of the things you didn't mention, I don't think, and somebody asked a question about that, is soy. Can you eat enough soy to replace estrogen?
I touched a little bit on it. Soy is a phytoestrogen, and I'm sorry I didn't. I didn't mention that, but again, with soy and some of the other phytoestrogen compounds, it can help with mild to moderate hot flashes and night sweats. But if a woman is soaking her sheets and soaking through her pajamas, probably not going to help. I don't think there's enough soy in the world that would help that. Unfortunately, I think it helps. But one thing I do tell my patients is that soy milk is loaded with calories, so you probably don't want to down a gallon of soy milk because first of all, it's not going to help, and then you'll get more of a middle spread.
Okay, Vivek, I'm going to give you the final question, and this is, totally philosophical. Why do we need sleep?
Don't know the answer.
You're the expert. Why do we need sleep?
Oh, this is something that comes up in every national sleep meeting. What's the function of sleep? And I
Right.
tell you, as a sleep society, we're still trying to struggle. I mean, there are probably, you can answer this question different ways. I mean, we definitely know just by our own experience that it helps us function better the next day, So those, again, not insomnia, but, sleep restriction is bad. So again, the two things are very different. Insomnia people may also be worried they're getting only 6 hours of sleep at night, but that 6 hours is different from a medical resident where we force them to get only 6 hours of sleep at night, okay? Okay, so we know that in that situation, if I restrict their sleep, they have absolutely shown to have higher error rates, higher driving accidents the next day, memory problems, so certainly sleep is good for things like cognitive functioning and memory.
Now, I thought I read somewhere that there was a cleansing function to sleep in the brain to cleanse out all
Yeah,
that.
that just came out very recently, again.
And I'm up to date on all this, so.
Absolutely, I tell you, this is, they did experiments in mice and rats where they felt that certain bad things that were floating around in the spinal fluid disappeared during sleep, and
It's good enough for me.
That's
right, it's good enough for
you.
me. Everybody, don't forget our next one will be on June 9th for a trauma. I want to thank everybody. If I didn't get to your question, I really apologize, but I have 3 experts up here that will be willing to answer your question in person, so come on up and talk to them, and thank you very much, and I hope to see you back in June.